Good morning, everyone. I am Dr. Jigyasa, and I'll be presenting about amblyopia management. Since amblyopia is a very elaborate topic to cover, I have decided to crisply touch upon all the management options available to us, and we'll be discussing a little bit in detail about the main ones. So amblyopia, as we all know, is the unilateral or bilateral decrease in best-corrected visual acuity caused by form sense deprivation or abnormal binocular interaction for which there is no identifiable pathology of the eye or the visual pathway. A thorough clinical evaluation is the key to diagnosis. As we have already discussed in the previous talks, for children, a thorough clinical history by the parents or any trustworthy informant is very necessary. Then we should test the binocular red reflex test. Binocularity or stereo acuity testing should be done. The evaluation of visual acuity has already been discussed. Fixation pattern should be seen in all kids. A central steady maintained fixation is essential. And binocular alignment and ocular motility should be tested. External examination and examination for pupil reaction should be done. A thorough ocular examination including the fundus examination and a cycloplegic retinoscopy with neutral density filter testing and testing for crowding phenomena. Now, management strategies for amblyopia are closely divided into the conventional therapy options and the new treatments for amblyopia. The conventional therapy includes optical correction, patching, and atropine penalization. And the new treatments include the intermittent occlusion glasses, perceptual learning, dichoptic learning, transcranial magnetic stimulation, and the pharmacological therapy. Now, optical correction is the key to management of amblyopia. In all cases, full optical correction should be given to all kids. According to pedic studies, spectacle correction alone have resulted in improvement of binocular visual acuity. 73% of children achieved a visual acuity of 6/9 or better within 1 year of starting treatment. Binocular visual acuity improved by an average of 3.9 lines, and children with worse visual acuity at baseline had greater improvement in the number of lines. Occlusion therapy is the mainstay of treatment for all amblyopia cases. It is the single most effective treatment for amblyopia and still considered as the gold standard therapy. The success rate is deemed to be 30 to 92%, and it acts by preventing the fixating eye or taking part in action of vision and removes the inhibitory stimulus that arises from stimulation of the fixating eye. So types of occlusion can be total or partial, conventional or inverse, and full-time or part-time. The ATS studies have discussed about the times of patching, the ways of patching should be done. I will not be going into details of the ATS study. The total occlusion prevents all the light from entering the eye, and it is employed in amblyopic eyes with acuity less than 6/24 or severe amblyopia. And occlusion is done using elastoplast or Doyne's rubber occluders or gauze pads. In partial occlusion, it does not cut off the total light entering the eye, it just degrades the vision. So various types of occluders are available to us in the markets, like adhesive skin patches by the name of OptiClude, which are the most popular. Then there are spectacle occluders and contact lens occluders. The question is when to initiate occlusion therapy. The answer is very simple. It should be best instituted as early as possible in early infancy because amblyopia at that time is amenable to treatment and it is highly cost effective. So atropine penalization is another way of deterring the better eye from seeing and stimulating the amblyopic eye. It leads to accommodation loss, optical defocus, and forced use of the amblyopic eye. The pedic trials have compared patching and atropine, and they have shown that visual acuity improvement is comparable between the patching and atropine penalization group. Intermittent occlusion glasses have newly come into the picture. An electronic device by the name of Ambly's liquid crystal intermittent occlusion glasses by the Expand group have been introduced. They are currently being used in the US and not available in India, programmed to unilaterally alternate between opaque and transparent phases at 30-second intervals. And they provide effective occlusion of the fellow eye 50% of the times that they are worn. So neutral density filters by the name of Bangerter filters are available, and they are placed on glasses of the non-amblyopic eye. They are as effective as the proper occlusion OptiClude patches, and they represent a lower treatment burden as compared to patching. They are more cosmetically acceptable to the kids. Perceptual learning Cambridge Visual Stimulator, the CAM uses a rotating disc which has a high contrast sine wave grating of 6 different spatial frequencies. After some training, the grating frequencies are consecutively increased, and the child is forced to visualize the change between the spatial frequencies. Recently, an adaptive optics perceptual learning system has also been introduced, and it measures and corrects the higher order aberrations in amblyopic kids. So video game play, there are various games available on the platform of amblyopia. These video games are associated with the release of dopamine. They promote neuroplasticity, and they promote binocular viewing. So binocular treatment of amblyopia study using video games, the Bravo study also talks about use of video games in amblyopia therapy. Dig Rush and Falling Blocks are few of these video games which are used in amblyopia therapy. Also, interactive binocular treatment is based on 3 different mechanisms: by presenting fine and movable stimulus to the amblyopic eye, by showing half of the image to each eye simultaneously, and third, by demonstrating identical images to both eyes with small retinal disparity. Virtual reality systems have also been used in the treatment of amblyopia. They are more acceptable to the kids, and the kids are really open to therapy by virtual reality systems. So transcranial magnetic stimulation has transcranial magnetic stimulation has also been used, although it is not really preferable. It uses repeated applications, and therapeutic options are currently under investigations. Pharmacologic therapy, basically by levodopa and citicoline, have been used in some of the kids, but they have not proved to be as effective. I will just summarize. Occlusion is still the gold standard therapy for amblyopia. No child should be denied trial of patching. Parental counseling is the key to good prognosis. Do not stop patching abruptly. A regular follow-up should be done for achieving maximal visual acuity, and always assess the compliance before deeming it failure of therapy. Thank you.